Hey, ardent fans and followers, how are you on your year and year? It's activist temperature, Professor Suresh back with altruistic enthusiasm for my 93rd video on annual of publication on YouTube today, 12th October 2020. Topic for discussion today is palliative treatment, critical care for chronic ailments. Palliative care, derived from the Latin root pallicare or to cloak, is an interdisciplinary medical caregiving approach aimed at optimizing quality of life and mitigating the suffering among people with a serious, complex illness. Within the published literature, many definitions of palliative care exist, most notably the World Health Organization WHO describes palliative care as an approach that improves the quality of life of patients and the families facing the problems associated with a life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. In the past, palliative care was a disease-specific approach, but today the WHO takes a more broad approach that the principles of palliative care should be applied as early as possible to any chronic and ultimately fatal illness. Palliative care is appropriate for individuals with serious illnesses across the age spectrum and can be provided as a main goal of cure, care, or in tandem with a curative treatment. It is provided by an interdisciplinary team which can include physicians, nurses, occupational and physical therapists, psychologists, social workers, chaplains, and dietitians. Palliative care can be provided in a variety of contexts, including hospitals, outpatients, skilled nursing, and home settings. Although an important part of end of life care, palliative care is not limited to individuals near the end of life. Evidence supports the efficacy of a palliative care approach in improvement of a patient's quality of life. Palliative care's main focus is to improve the quality of life for those with chronic illnesses. It is commonly the case that palliative care is provided at the end of life, but it can be for a patient of any age. The overall goal of palliative care is to improve quality of life of individuals with a serious illness, any life-threatening condition which either reduces an individual's daily function or quality of life of individuals with a serious or increases caregiver burden through pain and symptom management, identification and support of caregiver needs, and care coordination. Palliative care can be delivered at any stage of illness alongside other treatments with curative or life prolonging intent and is not restricted to people receiving end of life care. Historically, palliative care services were focused on individuals and incurable cancer, but this framework is now applied to other diseases like severe heart failure, chronic obstructive pulmonary disease (COPD), and multiple sclerosis and other neurodegenerative conditions. Palliative care can be initiated in a variety of care settings, including emergency rooms, hospitals, hospice facilities, or at home for some severe disease process. Medical specialty professional organizations recommend initiating palliative care at the time of diagnosis or disease-directed options would not improve a patient's trajectory. For example, the American Society of Clinical Oncology recommends that patients with advanced cancer should be referred to interdisciplinary palliative care teams that provide inpatient and outpatient care early in the course of disease alongside active treatment of the cancer within 8 weeks of diagnosis. Appropriately engaging palliative care providers as a part of patient care improves overall symptom control, quality of life, and family satisfaction of care while reducing overall healthcare costs. The distinction between palliative care and hospice differs depending on global context. In the US, hospice services and palliative care programs share similar goals of mitigating unpleasant symptoms, controlling pain, optimizing comfort, and addressing psychological distress. Hospice care focuses on comfort and psychological support, and curative therapies are not pursued. Under the Medicare hospice benefit, individuals certified by two physicians to have less than 6 months to live, assuming a typical course, have access to specialized hospice services through various insurance programs. An individual's hospice benefits are not revoked if the individual lives beyond a 6 month period. Outside the US, the term hospice usually refers to a building or institution that specializes in palliative care. These institutions provide care to patients with end of life and palliative care needs. In the common vernacular outside of the US, hospice care and palliative care are synonymous and are not contingent on different avenues of funding. Over 40% of all dying patients in US currently undergo hospice care. Most of the hospice care occurs at home environment during the last weeks, months of their lives. Of those patients, 86.6% believe that care is excellent. Hospice philosophy is that death is a part of life, so it is personal and unique. Caregivers are encouraged to discuss death with the patients and encourage spiritual exploration if they so wish. Advances in palliative care have since inspired a dramatic increase in hospital-based palliative care programs. Notable research outcomes forwarding the implementation of palliative care programs include evidence that hospital palliative care consult teams are associated with a significant hospital and overall health system cost savings, evidence that palliative care services increase the likelihood of dying at home and reduce symptom burden without impacting on caregiver grief among the vast majority of Americans who prefer to die at home. Evidence that providing palliative care in tandem with the standard oncology care among patients with advanced cancer is associated with lower rates of depression, increased quality of life, and increased length of survival compared to those receiving standard oncology care. Over 90% of US hospitals with more than 300 beds have palliative care teams, yet only 17% of rural hospitals with 50 or more beds have palliative care teams. Palliative medicine has been a board certified subspecialty of medicine in the US since 2006. Additionally, in 2011, the Joint Commission began an advanced certification program for palliative care that recognizes hospital inpatient programs demonstrating outstanding care and enhancement of the quality of life for people with serious illness. One instrument used in palliative care is a Edmonton Symptom Assessment Scale (ESAS), which consists of 8 visual analog scales ranging from 0 to 100 indicating the levels of pain, activity, nausea, depression, anxiety, drowsiness, appetite, sensation of well-being, and sometimes shortness of breath. A score of 0 indicates absence of the symptom, or a score of 10 indicates the worst possible severity. The instrument can be completed by the patient with or without assistance or by nurses and relatives. Medications used in palliative care can be common medications but used for a different indication based on established practices with varying degrees of evidence. Examples include the use of antipsychotic medications to treat nausea, anticonvulsants to treat pain, and morphine to treat dyspnea. Routes of administration, dyspnea. Routes of administration may differ from acute or chronic care, as many people in palliative care lose the ability to swallow. A common alternative route of administration is subcutaneous, as it is less traumatic and less difficult to maintain than intravenous medications. Other routes of administration include sublingual, intramuscular, and transdermal. Medications are often managed at home by family or nursing support. Palliative care interventions in care homes may contribute to lower discomfort for residents and dementia and to improve family members' views of the quality of care. However, higher quality research is needed to support the benefits of these interventions for older people dying in these facilities. For many patients, end of life care can cause emotional and psychological distress, contributing to the total suffering. An interdisciplinary palliative care team consisting of a mental health professional, social worker, counselor, as well as a spiritual support, such as chaplain, can play important roles in helping people and their families cope with various methods such as counseling, visualization, cognitive methods, drug therapy, and relaxation therapy to address their needs. Palliative pets can play a role in this last category. In the 1960s, hospice pioneer Cicely Saunders first introduced the term total pain to describe the heterogeneous nature of pain. This is the idea that a patient's experience of total pain has distinctive roles in the physical, psychological, social, and spiritual area, but that they are all still closely linked to one another. Identifying the cause of pain can help guide care for some patients and impact their quality of life overall. Physical pain can be managed using pain medications as long as they do not put the patient at further risk for developing or increasing medical diagnoses such as heart problems or difficulty breathing. Patients at the end of life can exhibit many physical symptoms that can cause extreme pain, such as dyspnea or difficulty breathing, coughing, xerostomia, dry mouth, nausea and vomiting, constipation, fever, delirium, excessive oral and pharyngeal secretions, death rattle. Radiation is commonly used with palliative intent to alleviate pain in patients with cancer. As an effect from radiation may take days to weeks to occur. Patients dying a short time following the treatment are unlikely to receive the benefit. Once the immediate physical pain has been dealt with, it is important to remember to be a compassionate and empathetic caregiver that is there to listen and be there for the patients. Being able to identify the distressing factors in their life other than the pain can help them be more comfortable. A patient has their needs met, then they are more likely to be open to the idea of hospice or treatments outside the comfort area. Comfort care. Having a psychosocial assessment allows the medical team to help facilitate a healthy patient family understanding of adjustment, coping, and support. The communication between the medical team and the patients and family can also help facilitate discussions on the process of maintaining and enhancing relationships, finding meaning in the dying process, and achieving a sense of control while confronting and preparing for death. Spirituality is a fundamental component of palliative care. According to clinical practice guidelines for quality palliative care, spirituality is a dynamic and intrinsic aspect of humanity and has been associated with an improved quality of life for those with chronic and serious illness. Spiritual beliefs and practices can influence perceptions of pain and distress as well as quality of life among advanced cancer patients. Pediatric palliative care is family centered, specialized medical care for children with serious illnesses that focus on mitigating the physical, emotional, psychosocial, and spiritual suffering associated with illness to ultimately optimize quality of life. Pediatric palliative care practitioners receive specialized training in family centered, developmental, and age appropriate skills in communication and facilitation of shared decision making, assessment and management of pain and distressing symptoms, advanced knowledge in care coordination of multidisciplinary pediatric caregiving medical teams, referred to hospital and ambulatory services, resources available to patients and families, and psychologically supporting children and families through illness and bereavement. The most common symptoms in children with severe chronic disease appropriate for palliative care consultation are weakness, fatigue, pain, poor appetite, weight loss, agitation, lack of mobility, shortness of breath, nausea and vomiting, constipation, sadness or depression, drowsiness, difficulty with the speech, headache, excess secretions, anemia, pressure area problems, anxiety, fever, and mouth sores. The most common end-of-life symptoms in children include shortness of breath, cough, fatigue, pain, nausea and vomiting, agitation and anxiety, poor concentration, skin lesions, swelling of the extremities, seizures, poor appetite, and difficulty with feeding and diarrhea. In older children with the neurologic and neuromuscular manifestations of disease, there is high burden of anxiety and depression that correlates with the disease progression, increasing disability, and greater dependence on caregivers. From the caregivers' perspectives, families find changes in behavior, reported pain, lack of appetite, changes in appearance, talking to God or angels, breathing changes, weakness, and fatigue to be the most distressing symptoms to witness in their loved ones. Within the realm of pediatric medical care, the palliative care team is tasked with facilitating family-centered communication with the children and their families, as well as multidisciplinary pediatric caregiving medical teams to forward coordinated medical management and the child's quality of life. Strategies for communication are complex as the pediatric palliative care practitioners must facilitate a shared understanding of a consensus for goals of care and therapies available to the sick child amongst multiple medical teams who often have different areas of expertise. Additionally, pediatric palliative care practitioners must assess both the sick child and the family's understanding of complex illness and their options for care and provide accessible, thoughtful education to address knowledge gaps and allow for informed decision making. Finally, practitioners are supporting children and families in the queries, emotional distress, and decision making that ensues from the child's illness. Funding for hospice and palliative care services varies Great Britain, and many other countries, all palliative care is offered free, either through the National Health Service (NHS) or through charities working in partnership with the local health services. Palliative care services in the US are paid by philanthropy, fee for service mechanisms or from direct hospital support, while hospice care is provided as Medicare benefit. Similar hospice benefits are offered by Medicaid and most private health insurers. Under the Medicare Hospice Benefit (MHB), a person signs up the Medicare Part B acute hospital payment and enrolls in the MHB through Medicare Part B with the direct care provided by Medicare certified hospice agency. Under terms of the MHB, the hospice agency is responsible for the care plan and may not bill the person for services. The hospice agency, together with the person's primary physician, is responsible for determining the care plan. All costs related to the terminal illness are paid from a per diem rate, approximately $126 per day, that the hospice agency receives from Medicare. This includes all drugs and equipment, nursing, social service, chaplain visits, and other services deemed appropriate by the hospice agency. Medicare does not pay for custodial care. People may elect to withdraw from the MHB and return to Medicare Part A and later re-enroll in hospice. In most countries, hospice care and palliative care is provided by an interdisciplinary team consisting of physicians, pharmacists, nurses, nursing assistants, social workers, chaplains, and caregivers. In some countries, additional members of the team may include certified nursing assistants and home health care aides, as well as volunteers from the community and housekeepers. In the US, the physician subspecialty of hospice and palliative medicine was established in 2006 to provide expertise in the care of people with life-limiting, advanced disease, and catastrophic injury. The relief of distressing symptoms, the coordination of interdisciplinary care in diverse settings, the use of specialized care systems include hospice, the management of the imminently dying patient, and legal and ethical decision-making in end-of-life care. Caregivers, both family and volunteers, are crucial to the palliative care system. Caregivers and people being treated often form lasting relationships over the course of care. As a consequence of caregivers may find themselves under severe emotional and physical strain. Opportunities for caregiver respite are some of the services hospices provide to promote caregiver well-being. Respite may last a few hours up to several days. In India, Tata Memorial Centre, Mumbai, has started a physician course in palliative medicine for the first time in the country since 2012. The focus on a person's quality of life has increased greatly since the 1990s. In the US today, 55% of hospitals with more than 100 beds offer a palliative care program, and nearly one-fifth of community hospitals have palliative care programs. A relatively recent development is a palliative care team, a dedicated healthcare team that is entirely geared toward palliative treatment. Physicians practicing palliative care do not always receive support from the people they are treating, family members, healthcare professionals, or their social peers. More than half of physicians in one survey reported that they have had at least one experience where a patient's family members, another physician, or another healthcare professional had characterized their work as being euthanasia, murder, or killing during the last 5 years. A quarter of them had received similar comments from their own friends or family members or from the patient. Despite significant progress has been made to increase the access to palliative care within the US and other countries as well, many countries have not yet considered palliative care as a public health problem and therefore do not include it in their public health agenda. Resources and cultural attitudes both play significant roles in the acceptance and implementation of palliative care in the health care agenda. The official publications of the College of Family Physicians of Canada provides an article on the stigma around palliative patient care. In this article, it states that many patients with chronic pain are treated as opioid addicts. Patients can build a tolerance to drugs and have to take more and more to manage their pains. The symptoms of chronic pain patients do not show up on scans, so the doctor must go off trust alone. This is the reason that some wait to consult the doctor and endure sometimes years of pain before seeking help. Palliative care meets the needs of all patients and requiring relief from symptoms and the needs of patients and their families for psychosocial and supportive care. This is particularly true when patients are in advanced stages and have a very low chance of being cured, or when they are facing the terminal phase of the disease. Because of the emotional, spiritual, social, and economic consequences of cancer and its management, palliative care services addressing the needs of patients and their families from the time of diagnosis can improve quality of life and the ability to cope effectively. Despite cancer being a global public health problem, many governments have not yet included cancer control in their health agendas. There are competing health problems and interventions being chosen in response to the demands of interest groups rather than in response to population needs or on the basis of cost effectiveness and affordability. Low income and disadvantaged groups are generally more exposed to avoidable cancer risk factors such as environmental carcinogens, tobacco use, alcohol abuse, and infectious agents. These groups have less political influence, less access to health services, and lack education that can empower them to make decisions to protect and improve their own health. Palliative care is an urgent humanitarian need worldwide for people with cancer and other chronic fatal diseases. Palliative care is particularly needed in places where a high proportion of patients present in advanced stages and there is little chance of cure. Ideally, palliative care services should be provided from the time of diagnosis of life-threatening illness, adapting to the increasing needs of cancer patients and their families as the disease progresses into the terminal phase. They should also provide support to families in the bereavement. Effective palliative care services are integrated into the existing health system at all levels of care, especially community and home-based care. They involve the public and the private sector and are adapted to the specific cultural, social, and economic setting. In order to respond to the cancer priority needs in a community and make the best use of scarce resources. Palliative care services should be strategically linked to cancer prevention, early detection, and treatment services for both adults and children. Palliative care provides relief from pain and other distressing symptoms, affirms life, and regards dying as a normal process, intends neither to hasten nor to postpone death, integrates the psychological and spiritual aspects of patient care, offers a support system to help patients live as actively as possible until death, offers a support system to help the family cope with the during the patient's illness and in their own bereavement, uses a team approach to address the needs of patients and their families, including bereavement counseling if indicated, will enhance quality of life and may also positively influence the course of illness, is applicable early in the course of illness in conjunction with the other therapies that are intended to prolong life, such as chemotherapy and radiation therapy. Includes the investigations needed to better understand and manage distressing clinical complications. Palliative care is a comprehensive treatment of the discomfort, symptoms, and stress of serious illness. It does not replace a primary treatment. Palliative care works together with the primary treatment you are receiving. The goal is to prevent and ease suffering and improve your quality of life. The purpose of palliative care is to address symptoms such as pain, breathing difficulties, and nausea, among others. Receiving palliative care does not necessarily mean you are dying. These things we have mentioned before. Palliative care provides relief from symptoms including pain, shortness of breath, fatigue, constipation, nausea, loss of appetite, problems with sleep, and many other symptoms. It can also help you deal with the side effects of the medical treatments you are receiving. Perhaps most important, palliative care can also improve your quality of life and provide help to your family as well. You don't have to be in hospice or at the end of your life to receive palliative care. People in hospice always receive palliative care. Hospice focuses on the person's final months of life. To qualify for some hospice programs, patients must no longer be receiving treatments to cure their illness. Palliative care tries to provide you with the expert treatment of pain and other symptoms so you can get the best relief possible. Our open discussion about treatment choices, including treatment for your disease and management of your symptoms, coordination of your care with all of your healthcare providers, emotional support for you and your family. Palliative care is a team approach to patient-centered care. Every palliative care team is different. Your palliative care team may include doctors, nurses, social workers, religious or spiritual advisors, pharmacists, nutritionists, counselors, and others. You may want to consider palliative care if you or your loved one suffers from pain or other symptoms due to any serious illness, has physical or emotional pain that is not under control, needs help understanding the illness and discussing treatment. It's never too early to start palliative care. In fact, palliative care occurs at the same time as all other treatments for the illness and does not depend upon the course of your disease. There is no reason to wait. Palliative care teams understand that pain or other symptoms affect your quality of life and leave you lacking the energy or motivation to pursue the things you enjoy. They also know that the stress of what you are going through can have a big impact on your family. and they can assist you and your loved ones as you cope with the experience of living with a serious illness. The palliative care team and your healthcare provider work together. Most clinicians appreciate the extra time and information the palliative care team provides to their patients. You may have to ask your healthcare provider for a referral to get palliative care services. Tell your healthcare provider you are thinking about palliative care and ask how to access palliative care in your area. Palliative care includes symptom management during both acute and chronic illness and end of life terminal care. Principles of palliative care are attitude to care, caring attitude, commitment, consideration of individuality, cultural considerations, concern, focus of side of care, to communication, communication amongst healthcare professionals, communication with the patients and families, the care, clinical context, appropriate treatment, comprehensive and multidisciplinary, care excellence, consistent, coordinated, continuity, crisis prevention, caregiver support, continued reassessment. Advanced care planning, important and potential difficult discussions are frequently necessary with the palliative care patients who are active, progressive, or advanced disease. Regarding breaking bad news, further treatment directed at the underlying diseases, communicating prognosis, admitting to a palliative care program, artificial nutrition, artificial hydration, medications such as antibiotics do not resuscitate others. Decisions must be individualized for each patient and should be made in discussion with the patient and the family. There is no one right or wrong model for the provision of palliative care. The best model is determined by local needs and resources in consultation with the local healthcare providers and authorities. Barriers in palliative care. First one, barriers related to the physician are poor prognostication, does not recognize how advanced the patient's illness is, may not recognize how much the patient is suffering, lacks communication skills to address end of life issues, believe they are already providing good palliative care and need no assistance. Misunderstands what a palliative care service does or has to offer. Does not want to hand over the patient's care, loss of control, loss of income, opiophobia, worries a patient may become addicted to opioids or suffer severe side effects, does not believe in palliative care, does not know of the palliative care service. Second one, barriers related to the relatives. They may never have heard of palliative care or local service can be managed. They may not know whom to ask about it. They may worry if they can afford it. They may fear that relatives and neighbors will say about home care. They may not want many professionals visiting the home. There may be patient-family disagreement about treatment options. They may feel unskilled and unable to care for the loved one at home. They may want the patient to stay at home or the hospital ward they are currently in. They may fear unexpected emergencies at home and do not know if palliative care service can cope with them. They may fear it may mean telling the patient they are dying, which may have been previously resisted. They may think it is euthanasia by another name, mercy killing. Barriers related to the patient thermo. They may have unrealistic expectations about the disease and prognosis. There may have been no advanced care planning discussions. They may not have heard of hospice or palliative care. They may suspect that it is dismal, gloomy, and frightening with people dying all around you and everyone talking about it. They may suspect that people die as a result of euthanasia. They may worry about opioid addiction. They may not want to leave home or the unit they are currently in. They may not want to develop relationships with the new professions. Fourth one, barriers related to society and culture, ethnic minorities, language barriers, poor or underprivileged plural communities. Dying and death still remain to a large extent taboo subjects. There is still a deeply held view that maintaining life, whatever its quality, is a prime responsibility of healthcare professionals and services. Opiophobia. So palliative care is beneficial to patients either at the end of life period or for reduction of pain for certain chronic illnesses. They learn to work along with the regular healthcare providers, either at patients' home or hospitals, whichever is preferred by the patient's relatives. Naturopathy like yoga therapy is one of the treatment options. Dietitian should be included in the palliative care team. Support of the close relatives besides society is also a must, as generally physical ailments lead to depression. With a strong willpower determination, one can circumvent most of the problems encountered in real life, whether it is illness or whatever it is. Debates, discussion, and open-ended topics like this can go on forever. Anyhow, let me pull the plug here. We'll meet again real soon with another interesting topic. Some of the statements, views expressed are solely mine based on limited knowledge gained over 6 decades of versatile experience. Always watch these videos with closed captions, subtitles for absolute 100% comprehension as per my sincere recommendation a zillion times over. I know I rushed through to complete the presentation within 20 minutes, which is a norm that I had set myself to retain the viewer's attention. But nowadays, I'm not able to stick to that because I make honest attempts to cover the selected topic more elaborately, including so many intricate fine details referring a wide variety of sources, in particular Wikipedia quite extensively, besides articles and books published recently. Besides, of course, I sprinkle my own salt and pepper and season it with my personal experiences so far in my life and also intuition. Stay at home as much as possible to maintain social distancing attributed to pandemic novel COVID-19 and prolong your lifespan. Lead a healthy life, God alone can put a stop to natural or unnatural events, maybe bio-war and cyber-war events like pandemics, which may lead to apocalypse and extinction of all sentient species on Earth for no fault of others. Rest in peace and harmony. Okay, take care.